Hey folks, welcome back to another episode of Straight Shot Health Talk. This is your host, Dr. Kevin Kukara, with my fantastic guest, Dr. Sharna Prasad, doctor of physical therapy and pain specialist extraordinaire. And Sharna, it's great to see you as always. Do you have anything specific you would like to talk about, or should I just throw this hand grenade?
Go right ahead. Go right ahead. I never think of what we want to talk about, so I'll go with what you pick.
All right. Well, this one was, again, these are from questions that people sent in at thepainwebinar.com, which is a monthly training I do every month. And they email me directly and just say, hey, I want to ask about a question about this to Dr. Kevin at straightshothealth.com. And the question, or one of the questions that we answered, or at least discussed on that webinar, was, is it necessary to process childhood trauma to heal from chronic pain? And what I really loved about this particular question is we're sort of in this realm, right, where there's the world of pain. There's the people who think acute pain is different than chronic pain. Acute pain is easy. Chronic pain is the hard, challenging stuff. And then there is a pocket of people who are doing really, really good work, and they still see pain in that dichotomous role, that somehow there's acute nociceptive pain and there's chronic pain. And then they're moving that, or they'll use the words physical and emotional pain, like acute pain's physical and then chronic pain is emotional pain. And they still haven't put in those pieces together. And they're doing some fantastic work. There's some apps designed around it. I've talked to many of the clinicians who are involved, and they're really, really good people. But it ends up with this. One of the approaches is, well, your chronic pain or your persistent pain now is because of this or the suppressed childhood trauma. And so one of the techniques that some of these clinicians do is they're processing childhood trauma. It's really important that you go back and you remember all these horrible events in your childhood, and then you express them by, sometimes they'll have you imagine you're there and beaten on pillows or things. And no question, for some people, it really works really well. But I would also say that for a lot of people, you don't necessarily have to go back and relive all those experiences in order to heal. We've seen it. I know, we know some of the people that we know who've done some really fantastic work. They don't do it. We're not ignoring childhood trauma, folks. I just want to make really sure that you understand that, because we understand and we know there's the science has this link between childhood trauma and what I call threat sensitivity, and how that relates with your brain processing information as you grow older, and how that relates to pain. So we're never ignoring childhood trauma. But I guess what I would say is you don't have to go back and do the Freudian thing where you're lying on the couch reliving all these events from your childhood in order to get better from persistent pain. But what are your thoughts on that?
I agree with you 100%. But I believe that as clinicians, we need to understand trauma. That's for sure. We need to be trauma-informed clinicians. And if you need more information on that, we have a great website called Trauma Informed Oregon that has short videos, great ways to get yourself informed. But we need to be trauma informed. That goes without saying. PTs have a big issue with trauma because they say, oh, they're talking about their childhood. I can't handle that. No. We have to learn how to listen to that. But does that mean we need to sit on a couch and process all those traumas? Absolutely not. It's beyond my scope of practice to be going over there. Absolutely. But let me give you an example, because I talk with stories, right? So if a patient comes to you and I say, tell me a story, and they start, when I was 9 years old and I was playing in the playground and doing monkey bars, and I fell from there and broke my back. Yes, I am going to listen to that story. I am going to acknowledge that that story has an impact on your pain today, because you were still thinking my back is broken when I was 9 years old. And my job is to assure you that, hey, your back is not broken, because physiology tells us that even if your back was broken, then it has healed. And it only takes 3 to 6 months for it to heal. So what you are having right now is a very hypersensitive brain. So, that story, I had a patient who told me that, she fell from a monkey bar, and it was so vivid. The story was so vivid because she said, I fell, and then I went to the lady who was managing the playground, and she said, yeah, just go to your classroom. And then I went to the classroom and my teacher saw me and she said, oh my gosh, you need to go to see the nurse. I went to the nurse's bed, where the bed was, and it was made of, whatever, Vexin or whatever the material. She said, I shook my head and the pebbles fell from my hair and I can still hear the sound of that pebble falling on that bed. It was so vivid, so I knew that incident had a lot to do with it. And all I did was just listen to that story and what it did to her body and how her body was reacting to that story. And I said, watch this. Just watch. You sharing that story is ramping up your whole nervous system. And that's what we're talking about. Let's bring you down to the moment and let's stay in this moment and just take a few deep breaths. That was her heart. And she said, and then I called my mother and my mother was not available to come and pick me. And I was in so much pain. And my mother's friend came and picked me. And I'll never forget her, the hug she gave me and that whole memory. Of course, that story has to be acknowledged. But does that mean that in therapy, we're just talking about when she was 9 years old? How did it feel? What was your mom doing? No, not at all. So anyway, so I had to share that story because that's what it reminded me of childhood trauma. And that's just one small story, but there is so much. We live in, where I work is a rural community. We have a lot of childhood trauma. The ACEs scores, adverse childhood experience. We have patients anywhere between 5 to 10 scores. It's very high. So we have to be very trauma informed. We have to be very kind about this. And we have to be careful when you're kind because sometimes their abusers were very kind to them. So that can trigger the whole process also. So being trauma informed is, I think, for physical therapists and all allied healthcare providers and teachers and everyone, the whole place needs to be trauma informed.
Well, if you're in any way, shape, or form involved with healthcare, you should be trauma informed.
Exactly.
Because we know the effects of early life stresses on physical and mental health, right? It's not like either or, it's and, which is again frustrating. And the majority of people that we're going to be seeing oftentimes in healthcare system have trauma because they are sick and they're distressed. So we need to be able to relate that in such a way. A couple of things that I want to clarify here is we were talking about childhood trauma and having to process it. That is very, very different than hearing someone's pain story and pulling out these meaningful events, which is what you did, right? So you're saying, you don't have to lie on the couch and say, well, just tell me about your childhood and I'm just going to sort of figure out, you have this suppressed anger because of all this trauma in your childhood. Says you listen to the pain story, and that is what I would call an anchoring event. And I tell clinicians that if your patient starts and it says, in 1962, and I can see the doctors, that has nothing to do with today's visit. No, it has. If that's where they're starting with their pain, it has everything to do with that visit because they're going to tell you what the memories were that creates the future meaning of their pain. And when we also understand the relationship between pain and memory, there is a very tight interplay. If you want to understand why you can vividly remember these things is because your brain is designed to do it. If you have these high distressful events, the brain is almost going to take a flashlight, or I should say a snapshot of it, in such a way to say, this is awful, remember this, so that if any sort of similar scenarios are in the future, we're ready. And so those anchor events are key, but that's not, lying on the couch or anything. That's listen to the pain narrative. Mm-hmm. And this reflects on something we talked about in, I think, the last episode was from a clinical perspective, so much of it is about the meaning. Mm-hmm. So if then you can take that meaning from that anchor event and then just to return a sense of control from this traumatic, my back was broken because I fell off of the monkey bars and it's always, never going to be the same, to, you had this event, your body healed, but what your brain did is it took this information in such a way and said, I don't want this to happen again. Mm-hmm. So I'm going to be hyper protective now. And now we're changing the dialogue in such a way that is returning a sense of control to the client. And mm-hmm. But that's not like what, people are like, do I have to go and write everything about my child? No, you don't. If you want to, go ahead. But from a clinical perspective, you don't have to do it.
Exactly.
And from a physical therapist standpoint, this is the other thing, because I know we've talked about this, is one of the parts from a physical therapy thing is, and when it comes to pain, is they're like, well, we're not psychologists. You don't have to be a psychologist. You're not going to be treating depression. You're not doing, all you're doing is listening to the story.
Right.
But,
yeah. And I had once a physician come in, and we were talking about pain, and it's like, well, I'm sick and tired of treating chronic pain patients because they come in and they tell you the same story 100 times. I said, wow, that's really hard, isn't it? But you know what? I didn't say this. I wish I had the guts to say that, but I did not. I said, if you heard the story and made them realize that you had heard it, like that's where that motivational interviewing skills come in, that reflective listening, that you help them listen to that story and had that story in your chart. So every time they came back and you referenced that, or you brought up something that they had told you last time so that they felt like you remember what they had told you. I mean, I had like extra detailed notes about their dog's name and, their kids' names and what they told me about that, because that's more important to them than telling them, do this exercise 3 sets of 10. Mm-hmm. As from physical therapy standpoint, we need to move away from that. Absolutely. We're done with that because nobody does 3 sets of 10. It's very, very annoying. But if you tell them that I like to go for a walk with my wife, and it says, hey, what about going for a 5-minute walk with your wife? Just 5 minutes. What do you think that would be meaningful? That's more meaningful than your 3 sets of 10. Sorry, I have my issues. I have my soapbox as I get on.
I love that because you can see interaction, like human interaction, it progresses, right? So we're sort of in this dance. Every interaction that we have with somebody else is sort of this dance, and we can either get stuck or we can progress or we can regress. Right. And if someone has told you the same story 100 times, you're obviously not progressing. so maybe you need to take a minute of time and appreciate the story. And once you understand that story, then we can take the next step. But until that story is understood, we're not going to go anywhere.
But that's where burnout is, right? Yeah. That's what you're talking about. If a patient is telling a story 100 times and the physician is feeling that, oh my God, here it comes again, you're just stuck. The patient's not benefiting, the clinician is running into burnout. Lose-lose situation. So something different needs to happen. What is that Einstein quote? I think you'll know it. I can't remember. Like you do the same thing with stupidity.
Again is the definition of insanity, but it's always attributed to Einstein, but actually it wasn't Einstein that said it.
It wasn't Einstein. So who was it?
I don't think they know. It was
okay.
This is totally off topic, but with quotes, a lot of times there will be a really great quote, and to give it substance, they'll attribute to somebody who's really famous. Those types of quotes, because it's a great quote. We just don't know who it's actually.
Who it was from. Okay, well, we won't give him credit then.
Yeah, but kind of returning on topic though. With that, I can, because again, pain, stress, everything is so tightly wound with outcomes that we have for persistent pain, and also so tightly integral to clinical burnout. And if you're not seeing the details, again, this goes back to universal pain literacy for healthcare providers. But when you're hearing that same story over and over again, one reaction is, this isn't telling me what I want to hear. They're telling me the same thing over and over again. It does nothing. And so we're going to have the same visit that we had every other time. I'm feeling I have 14 patients backed up. This is a waste of my time. All the stuff where now you're feeling outside of your comfort zone, or at least in a competent zone. Or the other way is like what you were saying, where you flip it. And you, instead of thinking, well, this story isn't important to me, the question is, well, what is it about this story that's important to them? And that is something, if you are a clinician, that's something that you can explore. So if you have a challenging client and you're hearing that story 100 times, and the next time in your visit, instead of doing the same thing over and over again and not listening, is to try something different. Well, okay, wait, if they're saying this story over and over again, what is it about this story that's important to them? And at least you're trying something different.
Right.
So maybe you're going to have a different experience. And it doesn't matter whether you're a physician or a physical therapist or occupational therapist or social worker, that little switch right there at least provides you a new path that you can at least explore.
And the fact that you're labeling a patient challenging patient, that is the time for you to say, what is the challenge in you that you find that this patient is challenging for you,
Mm-hmm.
not that the patient is challenging. Let's not label the patient, because it's our skill set that we are lacking, that we are not able to meet our patients. So it's a lot of accountability on our end, which, I mean, I think it's great, because I constantly like to challenge myself and say, oh gosh, I totally messed this up, and luckily I do have a few coworkers who are very good at debriefing and help me recover from my, oh gosh, I totally messed this up and all that. But it is always that, did our values clash? Did the clash? Was this patient expecting something totally different and I did not wait to hear it? And most of the time, it is when I am in a rush to tell them what I know. Oh my gosh, I can't tell you enough how many times have I regretted that I have not waited for them to be ready to listen to what I have to say. And in my rush to get them better soon, that I am telling, it's just like kids, right? When your kids are getting, younger, older and all that, and you want to tell them, don't do that. That's a dumb thing to do. But you can't tell them, because you want them to learn by, when they're ready to listen. And that's more meaningful. So that I do have a hard time with that sometimes, but lesser and lesser now. Sorry?
I think we all do.
I think we all do. Yeah.
I think that's another human nature thing, but at least if you are aware of it, then you can start taking the steps to address it. And an easy one for, you don't have to do this with a patient, folks. So what you just do is next time you're having a discussion with somebody, just kind of be mindful of how much are you actually listening to them versus, oh, I have something I want to say, and you're looking for a place where you can say it. And if you're honest with yourself, you're going to see that happens quite a bit. And that's human. It's nature, it's nature. But once you once you're a little bit more aware of these things, then you can start working on actually listening. That can be really, really hard work. I think active listening is hard, which is why I also think we don't do it all the time, because it is energy intensive.
Mm-hmm.
Yeah, telling is easy, listening is hard. So
yeah, listening is very challenging. Yeah, I do think that I benefited a lot from motivational interviewing. I do like their skills a lot, and how they train you and get back to it, and reflect. The reflective listening part, affirmation is their big tool that I like. Is catching your patient doing something right, and I love using that a lot. And it's like, I lost 20 pounds in the last year. And I was like, oh my gosh, and losing 5 pounds a year for me has been so hard. So hats off to you. Losing 20 pounds, that's impressive. And their eyes light up, and they see that, my God, the clinician is acknowledging how hard this job is. And yeah, it is hard to lose weight. We all know that. Mm-hmm. So I'm not faking it. I'm very authentic with my responses, and that tool is really that. If there's one tool you want to take away from, is the affirmation piece, that affirm the patient and give them that reflective listening.
Now, MI is really, really a great tool set, and there's so many kind of layers to it. When you're talking about it, made me think about one of my favorite classes I took in college, and I've been trying to figure this out, like when MI sort of came onto the stage, because we didn't have, it wasn't MI. The whole class was on reflective listening. So I'm thinking, because this was in the early 90s, that it was probably about, I should just look it up, but someone was taking the reflective listening. But I remember, because I did the class, and then I was a TA for a class, and the reflective listening, it was so hard. I mean, when you're literally taking 1 year in college all about reflective listening, that's probably something that more of us should kind of pay attention to.
I agree.
And then also just like, it's definitely not easy. And I should have been practicing it all my life. That would make things a lot better, but I obviously was not. So,
oh, we can beat ourselves or say, hey, tomorrow's another day. Let's start doing better. So, yeah.
Well, or give permission. Like, as I said, it is hard. And personally, I don't beat myself up all the time as much. I still beat myself up, but with recognizing is there's sometimes that you just don't have the energy to do it. And if you do that mindfully as well, it's the same thing as if you're on a diet and you recognize, I shouldn't be eating this thing, or, I know there's a should in there, but this is not the best thing for me, but I am going to do it. I choose to do it, and I'm mindful and I'm accepting the consequences of that. Um, then okay, fine.
Yep.
Same thing. If I'm not going to listen, I'm not ready to listen right now.
Mm-hmm.
Okay, but at least if you're aware, there's a point where you can choose to change. If you are unaware, change is really, really hard to do.
Exactly. And that's the big thing, is the awareness, right?
Mm-hmm.
So if you have clinicians who start becoming aware that what I've been doing has not been working, or what I've been doing can use a little bit more piece to it. Like, I had one of my coworkers, very new to our department, come to me and said, I'm an athletic trainer and I work with a lot of what do you call that, acute patients, but I want to know what can I to give them for preventive stuff. So I was like, yeah, I think you're ready for a conversation. Let's have that. I mean, we haven't had it yet, but I was like, yeah, let's get started on this. There's a lot we can share. It's not just acute, as we had talked last time. There's so much more to acute pain. Pain is pain. I mean, what more to acute pain? There's pain, and then there's pain. There's acute, and then there's chronic, and then there's emotional, and there's psychological or social. It's all pain. It's all has different contributors to the same experience. I mean, to a different experience. Just different contributors. That's what makes it so complex and so simple. It's complex and simple, and I don't know how to explain that.
Yeah, that's why I created the fire triangle, because if that an analogical comparison to something that is fundamentally so simple. Fire is fundamentally simple. Fuel, oxygen, heat coming together to construct a process. That process then is dynamic, and that process is influenced by all sorts of things. Once the process is going, you have the environmental factors, you have the weather patterns, you have the geographical topography that's going to influence it, right? And the same thing when it comes to pain is, if you just recognize there are these three fundamental components to it, and if you understand those, then everything else layers on. Like, then you can see how the social construct is, the environment that they're living is, the distress, whether it is micro distress or macro distress on the stage of, say, of a COVID epidemic. You can take this very complex process, reduce it, but you're not dumbifying it or taking away the beauty of just how complex this amazing thing is, but making it understandable in such a way that we can apply it and make it useful now.
Exactly.
Yeah. Anyway, I just want to wax on that, because pain is just amazing. I still get just absolutely chills just thinking about it, and people, oh, you're crazy or this. And I'm sure someone is actually is suffering, and they're saying, Dr. Kukaro and Dr. Prasad, you guys are crazy. This is horrible. But there's this complex in beauty in it that really underlines life. Like, and if you start understanding this stuff, you can, I don't know.
I know what you're saying. You've made me a painiac. I can't say you've made me, but you've kind of, this whole transformation started, and now it's like so nerdy. I'm like reading 1 or 2 articles every day, and then I'm forwarding it to my colleagues, and they're like, oh my gosh, here comes another article. But so I have to be careful that I don't forward too many. So, but yes, it is amazing. And I can't stop reading about it. And my kids are starting to say, okay, stop using the P word so much. So I have to, or if I start telling them something and they're like, we don't need to, so I have to keep remembering that part also. It's like, oh, yeah, stop, Sharna, stop giving your advice to everyone who doesn't need it, who doesn't want it,
Well, that's why I love about our chats, right? Is because when you have something that is so important and you want to discuss it because you just love it so much, and there's so many details. And I guess it's like anything, I'm sure there's an electrician out there that just absolutely loves being an electrician and understands all the wires and voltage requirements or whatever. And maybe they'd want to talk to me about that, but I am not an electrician.
Interested in that. And that's why I remember we would go on trips to, Washington or wherever. And then I was like, Kevin, I need to record this because I want to listen to this, and whatever you're talking, I want to hear it because I don't think I have the depth to understand all the words you're using. So I want to re-listen to it. So it was fun. I have a whole bunch of your recordings. I think it'll be fun to listen to them again to
No,
see.
they're always good chats. And that actually, so we're not going too long here, but we're talking many times about the importance of pain education for the clinician and in creating an embodied practice where you are delivering care through the lens of pain science, not poking them with pain science. You're delivering it through that lens, and that allows you to see as well as allows to deliver as well. I also think that it is the more that you understand pain, what you find is that it starts to expand beyond the micro. Like I see a lot of people focusing on really tiny things that sure they're important, but on the grand scheme, they're not. Like if you were focusing on ion channels, to be honest, unless you were like a molecular biologist or maybe involved in pharmaceuticals, maybe from a clinical standpoint, it's irrelevant. You want to be able to recognize it, sure, and kind of be able to tie it in maybe with your, if you have prescriptive authority, there's some implications there. But the rest of the time, it doesn't really necessarily matter. Instead, is like the macro thing is when you start looking at all this other stuff. What's the human dimension? What does it mean to perceive? What is it to mean when a brain constructs experiences emergently, but we perceive them in a sequential manner? What are the implications there? How do social dynamics interplay with this? How does communication impact this? What are the direct and indirect effects of language? What are the direct and indirect effects of a treatment? What is framing? What is staging? All this stuff comes together. And then, that's the part that gets exciting to me because it just starts expanding and
boom, 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 boom. Yeah.
Outwards rather than getting so tight. And then I get all frustrated when I see, when my physician colleagues and they're like, well, they just found this receptor subtype, blah, blah, blah. I'm like, are you in drug research? No. Are you treating patients? Yeah. That is not going to help your patient. This other stuff will.
Yeah.
And it's more fun too, I think.
And to me, the social factors are the biggest, then the psychological factors, and then it's the biology, which is the smallest factor. But if you address that whole thing, and they are big factors, but where is the patient leading you? And that's where the narrative becomes the most important piece. Because if the patient's leading you to the biology, then by all means, direct them to the biology, but then find out what else, because we know that the social contributors are the biggest contributors, So if you're not addressing those, then this micro thing that we are doing, this manipulation or, this whole discussion that we have on OMT and manual therapy and mobilization and all, it's in this micro space. Doesn't matter what you're doing. It's touch.
Oh, and
safe touch. Yeah.
I'm trying to jump in here. I'm not reflective listening.
You're fine. You're fine.
But because that's such an important point, because too often people do almost this mental masturbation of how they can justify what they want. It's sort of like talking, right? Is how they can justify what they want to do. So because they like to do it, it makes them feel better. Maybe it gives them a sense. And I do think there's a lot of ego involved, because now I can say I quote unquote fix the person. But I got into a discussion once, this was years ago, with a very, very well-known pain person. And we were talking about opioids and this, that, the other thing, and really these little doses, like someone who's on mega doses of opioid per day. We're talking 100, 200, 300 morphine equivalents a day. And they're taking 5 milligrams in addition to that. From a pharmacological standpoint, that amount is such a small, tiny amount that the direct pharmacological effects are negligible. And they were like, oh, we know that there's indirect and framing and blah, 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 all these other things that are just as real and just as important to any benefit with that 5 milligram dose in the face of overwhelming exogenous opioid. But then they wanted to say, well, a pharmacist was talking about how this small receptor subtype. And I'm like, now what you're trying to do is to take a piece of data that has not been confirmed, has not been reproduced, but what it does is it lets it fit into our existing biases. So if I use this pill, they get better. And now it's a direct effect of the pharmacologically, rather than what is the relationship with the patient, the framing effects, the expectation of what that therapy is going to do, because they focus on sort of these micro real details. PT space, I see it a lot with trigger points and dry needling. And it's the same, how could you say that you understand pain science really, really well and understand how pain is in the brain, and then pretend that your needle, mixing it in, stick it into a muscle belly to find some, sort of trigger, which nobody's been able to reproduce either manually or not. So who knows where we're sticking them in there, and that you're doing some micro modulation of a peripheral nerve that is fundamentally the core part of changing someone's human experience. Like, as an interventional pain specialist, I went to the DRG, which is a much bigger nerve and is a amalgamation, and I directly pulsed that, and the data sucks. So are we trying to reaffirm and to justify what we want to do, or are we actually going to step back a little bit and see the big picture of how this stuff interrelates? But anyway, that's my little soapbox that I had to get on. It is so frustrating to me.
It is frustrating, yes. And then they'll say, well, it's acute pain. We can give injections in acute and subacute. Oh, chronic pain is all in the head. I was like, oh, okay, all pain is pain. So if you are all about injections and all about, all these little interventions, you're still in that micro space. You are missing that big picture that we just talked about. So
yeah,
anyway.
Well, in the acute space, if there is a significant nociceptive contributor, then injections make a lot of sense. Like, if you are an anesthesiologist and you're doing regional anesthesia in the middle of someone who's got complex rib fractures, or you're doing it for preoperative care, meaning they're going into a surgery, and then postoperative care where you have somebody who's got this high nociceptive load, you are not, quote unquote, treating their pain per se. What you're doing is you're addressing the nociceptive contribution to their pain. But that is only one of many different inputs. Right. When we step back into the persistent pain realm, though, and we don't have that primary or strong contributor from a peripheral nociceptive component, your injection isn't doing anything directly. It's all the indirect effects that are important. And we've talked about this. The entrapment effects are the ones that are most concerning, because when you're externalizing control from the patient to you in a situation where that is inappropriate, ultimately you haven't done that person long-term good. You may have done. They short-term, they may be saying, oh, Dr. So-and-so, you quote unquote fixed me. But you haven't done anything long-term to return a sense of control, empower that patient, and get them back to living the life again, rather than seeing you all the time. Anyway. All right. Well, I'm sorry. I kind of went off and you kind of got me fired up there a little bit.
Well, that's what happens when the two of us start talking. We fire each other out. So it's that whole entrapment and empowerment piece. I love that analogy of yours, because I use it all the time, and it makes it so clear. It's like passive treatment, you're entrapping a patient. Active treatment, you're empowering that patient. You choose. Mm-hmm. At this stage, as a clinician, you choose, because I'm still teaching them pain science and I'm still doing manual therapy, but you're giving that implicit information to the patient that this person is touching me, manipulating me, and I am getting better, and he's fixing me. So that implicit information is harder than anything else. But anyway, that's.
So I don't think we've gone into depth. We've obviously talked about it a couple of times, but let's hold off and use that as another episode where we can talk about the difference between empowering therapies and entrapment therapies, and the importance from both a clinical as well as personal perspective. I think that would be a great future discussion.
We will do that.
All right. Do you have anything else that you would like to tell the listeners or viewers if they're watching this on video?
No, I think we've covered most of it. I say just be kind to yourself as you go through the changes in your belief system. Listen to the evidence, sit back, think about it, go back to the evidence, and see what kind of an emotional reaction you're going through, because it's challenging our belief system, and it doesn't happen that easily. So be kind to yourself. That would be my.
Yeah, no, that's a great point. It almost makes me think if people are like, oh, this is so easy. I'm like, well, then we're probably missing something, because it isn't. I mean, this is really a fundamental thing. It isn't easy, but anyway, you should definitely be kind, but it's a beautiful journey. It is a beautiful.
It's fun.
Journey.
It's very fun.
Unchallenging, like a really hard hike up the mountain. But anyway. All right, folks. Well, thank you for joining us at Straight Shot Health today. It was a wonderful discussion again with one of my favorite pain specialists, Dr. Sharna Prasad. Again, if you have any questions or if you have comments, things that you would like us to address in a future episode, you can email me directly at drkevin@straightshothealth.com. Also, this episode is sponsored by the Pain Webinar. Why is it sponsored? Because it's my webinar. We have monthly live pain training at thepainwebinar.com that you can participate in. And until next time, stay well. Thanks, folks.
Thank you.